says colonoscopists or endoscopists should make sure that they go and review the pathology before they send the results and confirm that pathology comes through and tell you they've set reminders for the next one. Never happens. It always falls to the GP to follow up all this stuff because we are the only accredited businesses, the only accredited practices in the whole health system. Yes, hospitals are accredited to different standards, but they fob everything off back to us. So we're there. Our reminder systems are chock full of stuff that, frankly, is everybody else's responsibility in the health system. All that work is unpaid.
What happens is as you increase volume, it might seem like, oh, it's fine. I'll just get people to come in or make a consult or appointment for everything. Well, the reality is that we all know that we deal with humans and a proportion of humans are compliant, concordant, as well as a proportion of humans are not. If we're doing a higher body of work, in terms of volume, then with that comes all the administrative work, and that is not paid at the moment. It's sort of stuff you do on the side, and we sometimes rationalize to ourselves, yep, I'll make them make an appointment so I can get remunerated for it. But the reality is, if they don't make an appointment, our professional values mean that you're going to follow it up until it's sorted, because you can't let it rest if there's an abnormality that needs follow-up. Hey, welcome today to our first Scale My Clinic emergency podcast. Today is Monday, the 24th of February, 2025. And over the weekend, very late on Saturday night or early Sunday morning, there were big announcements by the current Labour government about funding for general practice. And then they were matched and surpassed by the election rivals of the coalition. And so today, what we're going to do is a few things. In a moment, Todd is going to join me and we're going to walk through a summary of what's in store from the announcements. And then we're just going to unpick some of it to see what the main talking points are. And then finally, we'll finish with what practice owners and GPs need to be thinking about right now, today, so that you can be best prepared for what lies ahead. So, Todd, welcome.
Thank you, Sachin. In case of emergency, break glass. That's what we're doing here today.
No glass broken yet. I'll do that after. Cool. So, Todd, you put together a really useful summary that you were just showing me. It would be great to walk through that. I think you've got a document. If our listeners or viewers want that, in the show notes with this podcast will be the link to our social media. You can message us on there and we'll get this to you. Thanks, Todd. Over to you. Talk us through what's in store.
Pleasure. I've linked the actual press release there, and really interesting just from a political perspective that one party releases what they've kind of touted as a generational proposal for Medicare. And then within hours, the other party said, yep, we agree. And we think you should put in another $500 million for mental health services in particular. And so I think what's been done really well is the opposition have completely neutralized this in terms of its ability to play out in the election. However, that doesn't mean we as GPs and general practice owners should ignore what's been said. So the top line here, and we're just going to hold back on the information around more GPs and the ways that training is being funded. This is all focused around what is there for patients. The offer is $8.5 billion over 4 years in the forward estimates. And I just want to upfront, and the source here is the RACGP, that in 2024, the spend on general practice actually went backwards by $830 million. So 7% was pulled out of general practice in the prior year. It went from $11.87 billion to $11.04 billion. And just as a percentage of the total health budget, general practice is only around 6%, despite us seeing somewhere between 83 and 85% of the population in any 1 year. And the objectives for the Labor government here were to get 18 billion additional bulk billed consults per year. And they want to get the bulk billing rate to 90%, up from 77% where it is at the moment. And this is all going to come into play on the 1st of November 2025, of course, subject to them being in power. And I want to make it clear here that the 12.5% bonus payment is based on the item number only. That does not include that bulk billing incentive, and it's paid quarterly on clinics that have 100% of their services bulk billed in that time. And so that's a binary outcome by the sound of it, and something that we need to be careful of. Yep.
Before you show off the numbers, can we scroll back up?
Yep.
Because there's just something I noticed. which is 800 million down from 23 to 24. But if I'm not mistaken, inflation was running at like crazy amounts then as well. So in real terms, it may have been significant.
That would be more like a 12 to 14% drop potentially. Yeah, because your overheads have probably gone up 6% the year prior and then 5% in 2023 and probably 4% 2024. So yeah, that's true. Such an accelerating overheads, particularly relevant for owners. And of course, we don't have any guarantees as to what's going to happen in future with that.
Absolutely. So back to you. I just saw that and I couldn't keep my mouth shut. Sorry.
No, that's awesome. I just want to give some context for this data. This data in the table represents the Triple M, the modified Monash model for regionality, and blocks here are 1, 2, 3, and 4, 5, 6, and 7. Now, this doesn't work very well if you're listening to a podcast, so I'm just going to walk through block by block, but the MBS rebate for a level B is $42.85. The data from Cubiko in their report in early 2024 was for the average price for a private level B in 2023. So we're talking about data that's 15 months or more out of date now, but it was the most recent data I could get my hands on. I have made inquiries on up-to-date data. But what that means is if we're going to compare just the full amount of bulk billing that is now available for everybody, you don't need to have any concession cards to access this. We're just going to compare that to the private amount and ignore the 12.5% bonus for the time being, because that is very much an at-risk payment. It would just take one doctor to privately bill one consult and the whole payment is off. And so what that means is if you're in a triple M1 area for a level B consult and you are charging the average private for a level B of $81.21, this is 2023 numbers, then you would be $17 short on the new amount. If you were in a triple M2, you'd be $5.86 short. If you're in triple M3 to 4, which is the same classification, you'd be $3.86 short. At level 5, you would be $1.86 short. In a triple M6, you reach parity. You're actually 34 cents better off if you bulk bill. And in triple M7, you would be $2.74 better off if you bulk bill the patient. Now, there's a caveat here in the Health of the Nations report by the RACGP that came out in October 2020. The average duration for a consult was just under 19 minutes, but in rural areas, it was 23 to 24 minutes. And so whilst that 81.21 is a nice number to use, it's unlikely to represent the average for rural clinics. So what this means is that in most cases, if you're privately billing and you were considering, should I go back to bulk billing, you would definitely be worse off, and these numbers are out of date. It's going to be much higher now. If I go to a level C consult, and here I'm going to say to people, your level C private fee should be double your level B private. If I'm booking time with my accountant and I want 1 hour, they're probably going to say it's $500 or $600 for 1 hour. I don't get a discount for buying 2 hours. So I'm not going to get 2 hours for 50% off. So I encourage GPs that are listening to this and watching this to think carefully about how they set their fees, and do not discount your level C. About 70% of your billings will be level B for a face-to-face attendance item numbers, not including CDM, and around about 20 to 24% are level C. The other 6 to 7% pretty well makes up an even split of level A and D across the community. So effectively, 1 in 4 or 1 in 5 consults are level Cs. Do not screw yourself on your pricing of level Cs. And so here, if we pretend that a level C consult is $162.42 because it's double a level B consult for a private fee, not one of those areas comes even close. The closest it comes is within $38 of the new bulk build rate. So that tells us that this is not likely to be a winner if you're doing anything longer than a level B consult. And of course you are. And so that's worthwhile thinking about. Sachin, I might unshare now, and then we'll just go to a bit of a convo around pros, cons, where this might be advantageous, all of those kind of things.
Just looking at those numbers, so it sort of flies in the face of the evidence, which is slower medicine, higher quality medicine, the things that we've been talking about, trying to provide more resource for mental health, consults that take longer. This seems, from what you've just described, to go completely against that.
Yeah, 100%. I think the first thing is the feds have been pulling money out of general practice, and now they're promising to give you a little bit back based on you doing something else. I mean, that sounds a little bit like an abusive relationship in that they've kind of taken money off you. And then in order to get that money back, you have to perform a certain act. And the reality here is that in the vast majority of cases, this will be harmful to the practice. There's potentially a loss of autonomy here as well that comes through NHS by stealth, as you've sort of called it. So maybe as well as not favouring longer consults or more complex consults, which is a lot of what we do in general practice now, let's talk about the other things that this could be harmful for. Such, what are the things that you see as problems with this?
For me, the big thing here is there's a big push to be bulk billing. That's clear. And they've really nailed their flag to the mast with that. Like there's no doubt now about the direction that they're trying to push and pull people into. I think there's short-term and longer-term advantages and disadvantages. You're asking me about what are the potential pitfalls. And what I see is the big pitfall is in the short term, a switch would mean probably an increase in volume. Over time, this is from the NHS playbook, I can tell you this. It's exact. I would be so shocked if there's not some like new Labour pandering from the 90s involved here. But what I see happening here is that, first of all, the volume increases. It might be subtle. Is that an analogy of boiling the frog? You just keep turning the water up. See, the frog's not aware. I don't know who worked that out, by the way, who tried to boil a frog.
It would have to be the French, surely.
Yeah. And so then what happens is as you increase volume, it might seem like, oh, it's fine. I'll just get people to come in or make a consult or appointment for everything. Well, the reality is that we all know that we deal with humans, and a proportion of humans are compliant, concordant, as well as a proportion of humans are not. And so if we're doing a higher body of work in terms of volume, then with that comes all the administrative work. And that is not paid at the moment. It's sort of stuff you do on the side. And we sometimes rationalize to ourselves, I'll make them make an appointment so I can get remunerated for it. But the reality is, if they don't make an appointment, our professional values mean that you're going to follow it up until it's sorted, because you can't let it rest if there's an abnormality that needs follow-up. And so I think that volume of work is one of the big sort of Trojan horses here.
Can we pause on that for a moment? Because I just want to put it into real numbers. And again, I'm going to lean on some of the data from Touchstone that Cubiko put together. The figures they had were pretty clear that clinics, doctors that build privately tend to average around about 4 patients per hour, and that those that bulk build tend to average around 5 patients per hour. So if we say that you're spending 8 hours a day of consulting, which is a reasonable amount because you're probably going to have an hour or two of admin in there as well. So say you're doing 8 hours, then you're talking about the difference between seeing 32 patients versus 40 and maybe even more patients. Just for context, could you tell us how many patients a day an NHS GP would be seeing at the moment? Because I think a lot of people would think, 32 is a bit, 40's a fair whack. Tell me about, if I went to the NHS and I just said, open up my book for 8 hours, what would I expect to do?
It's obviously been a little while since I was there, but speaking to friends, which I do regularly, who are there, it's actually quite interesting. So when you look at the appointment book, it may not be that high in numbers in terms of the patient volume. And so you might look at that and think, right, look, that looks all right. Kushti, as the old Cockneys would say. So that looks great. Look at that. Easy. But it's not like that, because the NHS, the way it works is a large proportion of your time is actually spent doing asynchronous work. So what you might not see if you just looked at the appointment book is the 50 prescription renewal requests, and then the other paperwork that is required. And actually that makes up a significant chunk of a day's work, in 25% or so to 35%. The appointment book you might see 30 or 25 to 30. But then there's this whole chunk of other work, which carries with it all sorts of other risk that really, as clinicians, most GPs would prefer to be consulting with patients, not doing unpaid administrative work. That really affects both professional satisfaction and burnout. The things that people report is not normally the patient interaction that causes the burnout. It's the, oh my God, I've got all this stuff I have to do. And that's not to mention the compliance work that they have to do there to prove they've done what they say they've done. And so that's the other big risk I see coming here. Whenever there's an injection of money, and there is an injection of new money, it is going to come with more compliance activity. You can be pretty minded if you're increasing your volumes of work. You can quite clearly draw lines between higher volumes of work and higher likelihood of compliance activity.
Yeah, in the UK, that would be the QOF framework mostly, right? Yeah.
Yeah, it'd be QOF. There's the Care Quality Commission. There's various other audits and things you have to do. It's the PSR and Practitioner Review Program audit, all of those things. And you can quite clearly see those risks because when money has been invested into something, they want to make sure it's spent properly. And so there's incentives to keep as much of that money back as possible. It's just the way it works. And so I think that's one of the other big risks. And so along with that are the risks of burnout, stress, all those things that have been reported since the pandemic that we've seen, people reducing their consulting hours, etc. It's just another pressure on that. And then you've got this weird push and pull. You've got a push to actually increase your volume of work, which then causes some other effects. And so you could end up with quite a lot of unintended effects here. And I feel that the other disadvantage here is for clinicians who practice slower medicine, the medicine that evidence shows has better outcomes, whether it's chronic disease, mental health, women's health, those types of work. It's predominantly, my understanding is women who do that work. My concern here is all the efforts that have been made to highlight that work of being ignored by those who are making the decisions in power. And that's quite frustrating for us as a profession when we've been working so hard and we consistently demonstrate in evidence that the positive outcomes that come with that. What I like, and we'll come to this later, but what I like is that over the last 3, 4, 5 years, there's been a conscious push to decouple from the rules, say, and of what Medicare says you should bill versus what actually the work is worth. And probably people reading and hearing about those announcements over the last few days, their first reaction would have been, I've just gone to all this effort
To educate my patient base, put in place systems and processes.
Yeah, demonstrate value. And you're trying to undo that with one announcement to say free general practice for everyone. Well, actually, it doesn't work like that from a GP's perspective. And it's clear that the people who've made these decisions they won't have spent any significant time talking to actual GPs in practices. Of course, they will have listened to what they wanted to hear or wanted to listen to or heard what they wanted to listen to from representative bodies and then made that fit their prevailing narrative. So yeah, they're probably the big disadvantages. I think the other one, we haven't talked about some of the non-bulk billing stuff, but they've talked about increasing training places by, I think, 25% to 2,000 a year from 28. And then parental leave for general practice trainees, which is excellent. That's great. But the big one is about the new GPs. What we know from the UK's lessons. See, so we watch these lessons, you see these lessons unfold, and then we try and copy the same thing. So in the UK in 2015, Jeremy Hunt boldly stated 5,000 new GPs by 2020. Big number. And it just came out of his mouth and he said it. And actually in 2020, there were less GPs in the UK than 2015 when they'd said there would be 5,000 more. The total number was less in 2020 compared to 2015. And so you can promise everything. Todd, one of your favorite sayings is you can promise the world and you end up getting an atlas. Yeah. I think this is one of those classic situations because the reality is medical graduates are choosing their specialty.
Yeah, they're well informed. They're not stupid. They're informed participants in the marketplace.
Exactly. And so they look around, they see their experience and talk to people in all the different specialties. And the reality is this is just potentially trying to create a bigger gulf between general practice and non-GP specialists. And so they're going to have less honey with which to attract people to the specialty.
I think in business, Sachin, you and I know the reality here, right? It's really easy to sit down and put a number, and we call that a lag metric. Okay, you say, okay, cool, right? You're going to have 2,000 rather than the current sort of 1,600. How are you going to do that? And what's the lead activity required to get those people into there? And I think if they believe the lead activity is a few trinkets on the front end, and again, I think making sure that people have appropriate paid leave is great. If they believe that that is going to completely counter the lack of interest that people have in general practice and bulk billing more people, I think they would be sorely mistaken if they believe that's the lead activity required to bolster the numbers of people wanting to do general practice. Because as you say, you can only harness will. People have to want to do it. And in an ideal world, more people want to do it than you have places. What kind of, like we have been in more recent times, foundering to fill places. If everybody can get in and find a place and there's places left over, there's a big problem with the demand. And so I think that their judgment of what sufficient change is to bolster demand, I think they've woefully underestimated that, because it hasn't meaningfully changed general practice as a career objective or a career path. Yes, it's more appealing to patients. And so that promise from a political perspective is clever, because what they're saying to people is, hey, this thing you had to pay for, you can get for free now. The problem is that general practice is a private enterprise that is exposed to all of the inflationary pressures that everybody else is exposed to. And so inflation has been running really hot lately. And frankly, the revenue that comes from the MBS rebate hasn't even come close to keeping up with that. If you measured inflation, such as look at groups that have great lobbying power, the private health insurers, they typically get inflation that runs at about double CPI per annum, in my experience when I've looked back at it. And if you take the view that that's the health inflator, that health internal inflationary cost in health are larger than the external numbers of CPI that are used based on the basket of goods, then general practice has been badly stiffed over time, which is why you're seeing this move towards private billing. And so what private billing does is give you autonomy in that you no longer have somebody else calling the shots. And I want to circle back to the number of patients seen per day, because I think it's a really relevant metric for a GP. So I'm sitting here and I'm a private billing GP and I'm seeing 4 patients per hour. But if I decide to see 3 per hour, my revenue shouldn't drop, because I would be charging appropriately for that, right? So I could say in 8 hours, I want to see 24 patients, and I'm just going to adjust my fees so that there's no change to that. Now, I think if you're bulk billing, you're compelled to see 5 to 5.5 patients per hour. So that means that compared to that average doctor, the 4 patients per hour, you're going to see 8 to 12 patients per day more. So that means that over the course of the year, we're talking somewhere between 40 and 60 extra patient consults per week. And so you take that through to the year, you're talking 2,000 to 3,000 extra patient consults per year. But I want to circle back to the NHS and just use this as a bit of a salient point, because I know you didn't really nail down to what is the reality there. My understanding, and you correct me if I'm wrong, my understanding is that if you're doing face-to-face, you'd be seeing a patient every 10 minutes. Is that right?
Yeah, that's the standard appointment book.
Let's just say then that for the same 8 hours, that would be 48 patients per day, right?
Uh-huh.
So in order to maintain parity, if we continue down this line, and they're going for the NHS kind of volume model here, we're talking about an extra 16 patients a day. So extra 16 patient encounters per day. Again, we arrive at 80 per week if you're working 5 days a week. And if we run that out over the year, you're talking about 4,000 extra patient encounters per year. Imagine how much the tail is of that. One of the things you and I talk about is general practice has a fat head. So the consult can be really task heavy, spirit heavy, decision dense, really, really taxing work. And then the problem is it has a really long tail. So you have all these open loops for a long time. Hey, Betty, I want you to get a scan done in 6 months to follow up on this lesion in your lung. I need to refer you to public outpatients. That could be 3 years until you're seen in public outpatients for that particular problem. So I'll probably get a letter back in 3.5 years. So the cycle time on all these open loops is really long. And so you have a long tail. And so we're proposing that you add more stuff into the head and more stuff into the tail. And I think if you said to GPs, whenever I interview GPs and they say, what's the bit that you don't like? People don't mind working hard when they're there, right? But they don't love the tail, the long tail, because GPs are the bunnies for everything, right? And everyone loves an article. GPs should. They start that way. You know what? Fuck off. GPs shouldn't. You know, nobody ever says colonoscopists or endoscopists should make sure that they go and review the pathology before they send the results and confirm that pathology comes through and tell you they've set reminders for the next one. Never happens. It always falls to the GP to follow up all this stuff, because we are the only accredited businesses, the only accredited practices in the whole health system. Yes, hospitals are accredited to different standards, but they fob everything off back to us. So we're there. Our reminder systems are chock full of stuff that, frankly, is everybody else's responsibility in the health system. They're just sloughing that crap to us. And so all that work is unpaid. You get a letter from a specialist with a scope. You got to go and chase up the pathology on your time. You got to go and make sure that you read the standards and when they should be followed up, because you can bet it's not in the endoscopy report. Then you got to enter the reminder, explain to the patient what it is, sometimes get them in to talk about it. All this stuff. Could you imagine doing 40, 50, 60% more of that work for zero consideration, no money? I think this is what we really need to be careful about, because you've got to decide what train you're getting on to what destination, and is that where you want to go? Because at the moment, you do have a choice in this. And one way for GPs to be really clear about what's right here is to say, you know what, this model is not viable. We're not interested. You need to put something in there that is for us as well as patients. And while I'm on a bit of a rant, I'm just going to say, if the feds were serious about putting money back in people's pockets when they actually having cost of living pressures, as they are at the moment, the easiest way to do that is to adjust the bloody rebate. That way, if they're privately billed, they get more money back. Doesn't make any difference. They get more money back in their pocket. And you could do that. Guess when you could do that, Sachin? You could do it tomorrow. You could actually do that tomorrow, not say, I will do it in November if you get us back into power. You could just say, hey, we're going to change this because we know it's the right thing to do. We have stiff general practice of 7% of their total revenue, and they only get 6% of the total health budget anyway. Hospitals are gobbling up all of that budget. And you say, actually, you know what? We're just going to put all of the money back into the rebates. And if you still choose to bulk bill people, there's a bulk billing incentive as it currently stands now. And that would actually address the cost of living pressures, because it puts actual money back in the pockets of patients. What they're proposing to do is to pay all the money to GPs on the basis the GP agrees to a haircut, and they think, oh, well, they're all altruistic souls generally, until they listen to this podcast, and then just hope that they'll take a haircut, do some extra work, increase the volume of unpaid work on the basis of the public good. I'm just not convinced that's a great offer.
I think you're right, Todd. The reality is exactly as you've painted it. I think the good thing here is nothing's happening today and nothing's happening tomorrow. That's also the bad thing, because as he said, something could happen today and it could happen tomorrow, but that's not the thing they're choosing. And the reality is that this is a vote-winning exercise. It's easy to tell people that they're going to have free general practice, which is what is being messaged. And so it's easy. And really, if you're a cold, hard number cruncher sitting in Canberra and you're just deciding my outcome is to win the election, I can piss off 5, 10, 15,000 GPs or 20,000 or whatever it will be. There's 40,000-ish here, and a substantial proportion won't care. So maybe you've pissed off 10 or 15,000 people, but that person's probably calculated that, oh, you know what? That might add me 500,000 votes in these key seats. And that's all this is. GPs, once again, are the pawns in a game. The slightly ironic part in this is what you mentioned right at the top of this, which is that as soon as the current government mentioned it, the opposition matched and raised. And so it sort of is not even on the front page less than just over 24 hours later, because other stuff is more interesting. That has certainly been eye-opening. I suppose we've talked about the things that you could trip up over, the potential concerns. There's some good in this, and I think it's important to just acknowledge that. And as well as that, there's probably just some thinking about what practices and GPs need to be thinking about right now. What I'd love to do is just maybe spend a bit of time on what's the good? Where's the good in this? There'll be some good.
It's a good question. I think the first thing is that general practice is front and centre at an election. The reason this policy has been announced early is because they're nervous about it. People are getting frustrated with accessibility and affordability issues, and there's no better value part of the health system than general practice. So I think the fact that that is being spoken about is great. This is actually proposed money to go into general practice. So I think, again, that's a great thing. You would never expect them to propose more money without there being heavy conditions upon it. So again, I think we shouldn't expect politicians to not play political games. But in terms of the type of clinics this would benefit, there is no doubt that the types of clinic this benefits are ones that are either mandated to bulk bill or through some kind of a remit, such as community health centres and maybe a lot of aged care facility care providers. Bulk billing may well be their choice because it's difficult to use other modes of payment in those environments. So there's no doubt that will make that type of care more accessible. Urgent care clinics, community health centres, aged care facilities may well benefit. The other group that this will probably help is people that are currently formulating plans to move to private billing. I'm quite sure they'll be deferring or delaying those plans. When I did an analysis on the triple bulk billing incentive and the amount of time that bought the government, it was only 15 months. So I actually think that if clinics do delay, it's probably only going to be by somewhere between 1 and 2 years before they say, you know what, our prices, our overheads continue to inflate. We're going to have to be forced to make these changes. The other area, this sounds like a really weird one, but if you focused on level B consults only, so you just said, we don't do long consult. It's just one problem. That's it. If you want to deal with more than one problem, you've got to come in more times. If you did that and you're in the triple M areas 3 to 7, you could potentially create a viable business model. I think one thing that you've got to take in mind here is you and I are not recommending this is the type of medicine for people to receive. We're just saying in what circumstances would this model make sense? The other question I had here was around telehealth services provided from alternate locations into triple M 3 to 7 practices, because those are usually of a shorter duration and would need to be augmented by in-person care, of course. But there is a potential for clinics that are in triple M 3 to 7 to potentially augment their service delivery model with GPs working from elsewhere and providing telehealth services into those. So they might go from 85% in-person, 15% telehealth. They could potentially flip that and run a model where they were predominantly telehealth and potentially bulk billing those services and private billing their in-person, just so there was a disproportionate reward for the work done locally. That's one model that this kind of suggests may well work. And maybe we'll talk about just who it benefits before we shift into who it doesn't benefit. Any more thoughts on that, Sachin? Who do you think benefits from this model? And when I say who, I mean what type of practices?
Yeah, well, for me, I think the corporates.
Their fingerprints are all over this, right?
Yeah, there's been some been stuff going on
Yeah,
in the background that we're not party to or privy to related to corporates being involved in this, because large corporate entities, there's a nice intersection for them between bulk billing, the extra bonuses, payroll tax, even though that's state related. Like there's a whole sort of a Venn diagram intersection there that I don't really care because I don't give
it. Does play nicely into that, as you say. They'll meet most of the requirements on a state-based level for not meeting the requirements for that. So this could make it much easier for those businesses to be packaged up and then relaunched on the ASX, right? So we should see a few private equity-owned enterprises come back onto the market because the valuation has just been bolstered by those changes. I think that's actually a really relevant thing for us all to think about. Who has the ministers here?
100%. So for me, they're probably the big other winners that we haven't covered here. At the same time, private practice owners or people who are privately billing some people will be feeling very nervous right now, and we'll come to what you need to be thinking about shortly. But I don't think we need to react. We've just got to calmly approach this. But it is interesting to see which people will benefit. What about the ones who won't?
Yes, the enterprises, the practices and the GPs that are going to be disadvantaged if they were to say yes to any of this. Existing private clinics, we did a walkthrough, unless you're sort of triple M 6 or 7, it's unquestionably worse for you to bulk bill these patients rather than privately bill. And I think the 12.5% bonus should be treated as a bonus, because it'd be really easy to have a misstep. And if you have independent GPs, you're not able to dictate their billing. There would kind of be a perverse incentive for people to break ranks unless they're employees and could be directed as to what to do. That would then present that capital is at risk and I think should not be included in any calculations, the 12.5%. I think that's also, if you were to kind of plan to receive that, then the arrangement between the clinic and the GP would be much more like an employment agreement, because you would have to be dictating the billing rules in all cases. And so if you were going to do that, you're probably better off just to assume that you are employing your GPs and actually move to an employment standard basically for that. And they're probably the main ones. I think that there's no reason really for people to jump or make any decisions based on what's been discussed so far. I think the other thing to keep in mind is this is the first salvo, right? This is just what the feds have suggested that they're going to do. The things to take away from it is they've committed an amount of money which is substantially higher than ever committed before. And we should all remember as GPs and practice owners that their commitment to spending on general practice has gone backwards. So they owe the public. They already owe the public half of what they've promised just in terms of keeping pace with the old commitment. That's not even inflation adjusted. So we could make a valid argument that they're really not putting their money where their mouth is because they're not really putting much in the way of guaranteed capital into general practice. So the public really could say, hey, look, you know what? Put your money where your mouth is and actually increase those rebates so that when we do pay, we get more money back in our pocket. That's what they should be seeing rather than going by proxy to the GPs, asking them to take a haircut, and in return for that haircut, patients get care that's free at the point of service. So I think that's probably worthwhile thinking about that this is the beginning of a dialogue, and our advice would be that you go really hard at the opposition to get them to tweak and change it, because that's probably the easiest way to get the federal government to change it at the moment. They're going to be really wanting to see, I mean, imagine the Labor Party thinking, geez, the Libs are looking more socially progressive than we are. If you could get them to change it and just reposition where the funding goes, Labor will fall over themselves to come into line because they'll be mortified to think that the coalition is considered more socially progressive.
Absolutely. In terms of silver linings and what we do next, there's one silver lining that I think is easily overlooked. I talked about the NHS by stealth and had a good stab at the NHS, which I will do intermittently. But the one difference here is that we do have the autonomy to charge. And in the NHS, GPs stuck. They can't do that. And so the ability to charge and have the choice to charge, the ability to bulk bill some services and charge other services allows good flexibility in your product and pricing matrix that you might choose. And so that setup just means that it just creates a lot more options for practice owners here than in the UK. And so you can hear NHS and think it's going to be just like the NHS, and things may change. And certainly they're taking inspiration from a lot of the NHS playbook. However, that one thing that general practices here can bulk bill some services, charge for others, does allow a good deal of autonomy. My concern is this push to try and corral people and almost coerce people to bulk bill. The concern for me is that that autonomy starts to wane over time, especially if you're within organizations that are then hanging on the 12.5% in order to satisfy shareholders. You can really start to get quite significantly as a GP, not even as an owner, but as a GP within that corporate setting. One would have to be concerned about clinical governance, financial incentives potentially being perversely positioned against clinical governance and clinical autonomy. And I think there are significant concerns there about that from my perspective, because if there's shareholders have to be satisfied because the 12.5 bonus is in the profit models or whatever, and dividend models, and then GPs want to do something else because it's clinically necessary and want to charge for certain things and they're not allowed to. I think as a GP, I'd be wanting to be much more confident in a private setting. And so I think that's important. So we should talk about what next. What should a practice be doing now?
Yeah, I think one really important question here, a number sticks in my head that is probably the foundation for all of this. And this is a recurring theme, that GPs on average spend about 18 minutes with each patient. That's probably the amount of time it takes GPs to do good medicine. And let's pretend that you could get an efficiency dividend by using, say, AI transcribing tools and some other things that knock 2 or 3 minutes off. And let's pretend you could get it to 15 minutes and that the patient experience and the quality of the consult remained the same. I think that's viable to say you could get something from 18 minutes to 15 minutes. It isn't really viable to go to 10 minutes, I think, and do good medicine. So the first decision is here. Whereabouts do you want to play in the spectrum? There are lots of different positions you can occupy in a spectrum. Let's say there are broadly 4. There's the cheapest, and in our case, that's bulk billing. That does mean you have to do more volume of work. Like, there's just no two ways about that. And I'm not meaning to denigrate cheap, because I think there is certainly a place for that. But you would reasonably expect that those doctors would want to salary maintain with others, and so they do need to do a higher volume of work. Then there's something towards the lower end of the middle, your cheap premium. There's premium, and then there's high end, the equivalent of Louis Vuitton. And those people, their MBS rebate won't really matter because they're paying for boutique services. But those other two levels matter a lot, like the private, where it's a little bit above the bulk bill rate, and those that run a fair way above. And so I think it's really important for people to make some decisions. You're going to spend 25, 30, maybe up to 40 years doing general practice. What type of GP do I want to be? That's ultimately the question to ask yourself. Do I think I can do the best work seeing 5 patients an hour and providing a big impact on the community because I'm doing it free, and therefore I'll probably do more kids and less complex care, or and more transactional consults? Or do I want to get in, roll my sleeves up and do the longer work? And we know that group is disproportionately women. So I think you touched on this earlier, but if we're to maintain equity and equality, I don't think that can be bulk bill. Like, it just can't be. And the shock not accepted by the GP. That's like they have to stick the knife in the PowerPoint in order to help their patients. It doesn't sound to me like it's a viable long-term solution. And it entrenches gendered pay gaps. And so I think if we're going to do that, you're going to see that bulk billing models are going to be predominantly men that are doing that type of work, and it will predominantly be in corporatized environments. And you don't tend to see that in the community health center environments because they're salaried and so have the same pressure. So I think if this is to be accepted by clinics, it will see a separation of the types of clinics that are offered, because there will have to be a separation between bulk billing and private billing. And the gaps will get higher because the inflationary pressures in running clinics and just being a human are higher. It costs you more to do all of the things that everyone wants to do in life. Insurances go up well beyond inflation, utilities, all these sort of things. No doubt that will be an issue. I think if I was to jump ahead in time and I was the minister, so for a moment I'm jumping into the shoes of the minister, if this flies and a certain number of clinics do receive the 12.5% bonus, the next thing I would be thinking is people signing an annual agreement where they have to actually commit to doing this in advance, but the payment is deferred. And so then you've got a contract arrangement with a practice to provide bulk billed services to a community. If you're to take this to a ridiculous extreme, then I've kind of locked in my clinics that are bulk billing clinics, and they might receive separate branding. It could be an extension of the urgent care type arrangement, and they may well have different item numbers that they can use as well for, say, consumables and things that are currently part of what you would privately bill. So there would, and then those clinics would also have a further separation of payments to the individual GP and payments to the practice. So again, they're much more likely to be an employer-like relationship because you're going to get a fair chunk coming to the contract holder, which will be the practice. And this is complete speculation, by the way. I don't have any inside knowledge. No one's talked to me about this. But I was thinking, if that NHS advisor was there, what would they be suggesting, Sachin? And that's probably the way that I would run it if I was looking for locking practices down, and I politically believe that the bulk billing label was advantageous to me winning the next election. That's what I'd be doing. I'd be looking to lock those clinics down to commit in advance to what they were doing rather than retrospectively getting paid. How about you, Sachin? How would you make Australia into the NHS?
Well, after I replaced you in your role, what I would be doing next is to say, well, now these people are reliant on me as government, and the funder. And so now I'm going to make them jump through more hoops for that same money. I'm going to check that they're doing things properly, because if they're not, then I should really take some of the money back. And then I'm going to raise the bar and the thresholds to get the same money. So I get more for less. Because really, now I'm in charge, because their contract is with me. Their money comes from me. They don't really have easy other places to get it. And so they're going to want to dance to my tune. So that's what I would be doing. And that is exactly what has happened in the NHS. And so that's standard playbook. So probably we should now just talk about practice owner. You're a practice owner now, today. You've heard this over the weekend, or you're a GP and you've heard this over the weekend and you think it's doomsday. I've heard all of this. This sounds terrible. Or maybe you have a bulk billing practice and you're a GP who works there and thinks, yeah, this is awesome. Suddenly, all those people who come to us without concession cards, we're going to be quids in. What do you think, if you're a practice owner right now, that you should be thinking about and focused on?
Yeah, I think the first thing is you just run an all hands meeting and find out who knows what. Is everybody briefed on the information? Because the problem is, of course, people are going to be ringing the clinics today saying, hey, I've heard you're bulk billing me, which is exactly what politicians want. So the first thing is it's going to waste a lot of your time addressing false claims from politicians. And so you need to have a conversation as a practice. And you just need to hear all the views, really, as to what do people like about it, what are people concerned about, what response, if any, are they thinking we need to take now, but not committing to any course of action. And this is not once and done. You're probably going to need somewhere between 5 and 10 group conversations like this, and then separate conversations with GPs alone, because it primarily affects them. But your admin team, I think this is often given insufficient airtime, but the admin team need to buy into what you're doing as well. Ultimately, at the front desk, they're the ones telling people this is how much it costs, and you need to come back to the front desk to pay for this. If they don't buy into this and they don't believe that your clinic delivers on the value of that, there's a bit of hypocrisy in them asking for the money. We see that a lot in clinics that have really large outstanding patient accounts payable, because the front desk team don't ask for it. They don't believe that general practice should be private. The first thing to do is to have a lot of conversations about this. And I think this would be easy for GPs and owners to be divided on. And I want to be really clear here that the corporates are sitting there waiting for privately owned general practice to fall over. They will snaffle it up. If they do that, GPs are screwed, and I think patients are screwed. Not because the doctors in corporate-owned practices are any worse, but because the corporate set an environment that benefits the corporate, not anybody else. And so I think that if we firmly believe that privately owned general practice, the vast majority of those are owned by GPs, if general practitioner-owned general practices is better for the community, then I think we need to make sure that we work together on this. So I strongly encourage you not to work against each other. And things like that 12.5% bonus can easily drive a wedge between doctors and clinic owners, because they feel like they have goals that are at odds with each other. You do need to come into alignment there. Remember, talk is cheap. The feds can talk about whatever they like. Ultimately, you're responsible and accountable for the way you respond. What I would caution you against is any early response. So if you put your hand up and go early, then there's a good chance that all of your patients that were prepared to pay privately, guess where they're going to go, Sachin? They're going to go down the road, right, to the clinic that maintained private billing and is still seeing 4 patients per hour, because they're prepared to pay for that premium experience, and they'll know that it's hurried and the waiting room's full of people and doesn't feel like it used to feel. I think it's important that people recognise the consequences of a change, and that if you are going to change, reversing your decision is not going to be easy. So it's better, as our buddy Michael Bangay-Stainer would say yes, but more slowly. If you are considering saying yes, don't go early in November. Just talk a lot about this and make sure you've got all of the information before you make that. And then we talked about this earlier, but you need to communicate with your team internally, and then with your population, both patients and the community externally, just to make sure they're kept abreast of exactly what's going on. Because you won't be surprised to learn that the politicians will tell them half-truths. And I haven't heard any politicians saying, hey, we ripped $830 million out of general practice last year, so we're going to give you some of that back and thank us for it.
Yeah, I think the advice you've given is exactly what I'd be saying. Number one, you need to really maintain the narrative with your team, with your patient base, and both your team being both the employed and not employed team. Like, there needs to be really open, clear discussions within the practice. Podcast number 5, we talk about the fundamentals of privately held practice in Australia. Worth going back to that. The link will be in the show notes. So that's a good listen for your employed team, and then having a conversation. So I think that is super important. With patients, I think we need to get better as a profession, really explaining to them a lot of the day-to-day things that we talk about in terms of how it is for general practice and the costs of running a practice and the costs and the value of high quality care. Of course, Todd, we talk about this all the time. Like, there's only so much talk. They need to experience like high value care first. And then we need to, once they've experienced it, we need to then explain how that is delivered, because then they appreciate it. No point telling them it's great and then giving them a crap experience. It doesn't work that way. They have to really experience a really great episode of care in your practice. And then we need to continually be communicating about the importance of that higher quality experience continuing and how it's delivered and the resources required. But if you tell people and shout that you're great and then have a crap experience, well, I think we've all been there. We're not going to enjoy that. The second part, I think, Todd, is all these assaults on our attention, these announcements or promises or whatever they are from government, they can really steal your attention and your focus and your energy. And so as a practice owner right now, there are probably hundreds of thousands of dollars of value sitting in there that you're just letting slip day by day, week by week, year by year. And it's easy that a media headline then takes your focus and you start worrying and thinking about that, but you forget about all the opportunity that's in front of you right now. And so, and we talk about this a lot, all of the time with lots of the people we work with, but you've got to focus on now and the things you can be doing right now. Yes, you need to be able to anticipate and think about the future, but the reality is it's now that matters and taking actions now. And for some people watching or listening to this, you may not take action today, which means your practice may not be around in 6, 12, 18 months when these purported changes may or may not eventuate. And so what I would say is don't focus on tomorrow at the expense of today, at the eventual expense of tomorrow. Not worthwhile doing that. Cool. I think we're going to stop there. That has been our emergency podcast on the announcements of the potential changes to Medicare and rebates over the next Parliament. Thank you, Todd, so much for doing all the number crunching. That was fascinating. If you want a copy of that document, drop us a line on our social media. The links will be in the show notes, and we'll see you again next week. Bye.